Our next program is Reengineering Ambulatory Care of the U.S. Department of Veterans Affairs, and our presenters are Mark Graber, Chief of Medical Service for the VA Medical Center, and Joanne Holland, Associate Chief of Medicine of the VA Medical Center. Welcome.
Thank you. In 1992, we critically examined our delivery of outpatient care and asked, how can we provide truly personalized primary health care to the over 20,000 veterans enrolled in our VA clinic system where historically care was fragmented and episodic? We began with the formation of 4 primary care teams. We named these blue, yellow, red, and green. We chose these colors for ease of recognition, to serve as a foundation for familiarity for patients and staff alike, and most importantly, to parallel our intent, the establishment of a patient-centered approach to health care in our facility. Our outpatient primary care teams began operation in July of 1993. The patients and staff were drawn from diverse pre-existing programs and clinics. Each team operates as a group practice where medical care under the direction of a personal physician is closely supported by nursing, social work, nutrition, pharmacy, and health psychology. We expanded our scope of services, added evening hours, re-educated patients and staff, and improved access to care. The results were that our veterans no longer needed to rely solely upon the emergency room as a place to get help between scheduled clinic appointments. Concurrently, we began integrating our medical subspecialist physicians to primary care. This maneuver augmented physician staffing in primary care and provided a forum for subspecialty physician retraining. The multi-specialty group practices promote primary care as an attractive career option for medical students, interns, and residents. By July of 1994, the primary care teams extended services from ambulatory care to the inpatient medical units. This step ensures that our veterans remain under the care of their health care team while acutely ill. Enhanced discharge planning and utilization of home care services have reduced the length of many hospital stays. Our aging veterans have benefited from geriatric programs specifically designed to maintain independent living. These measures serve to postpone and potentially avoid nursing home placement. The integration of our patient services under the direction of a dedicated, multidisciplinary primary care team means that our veterans are better cared for.
We feel that our primary care program has many unique and creative features that we would like to emphasize to you. In terms of novelty, this represents a fundamental change in the way we do business. Our new mission is quite simple. We put the patient first. This is a dramatic change from the old VA philosophy, which emphasized rules, regulations, and the system. A second unique aspect of this program is that it was based on principles of empowerment. Others in the room may disagree, but we feel quite certain there is no government agency more pyramidal, more bureaucratic than the old VA. A key element of this reengineering project contributing to its success has been the involvement of frontline people in both the design and running of this program. When people who have been providing a service participate in redesigning their own system, they take pride in their achievement, they have the energy and enthusiasm to effect a major change. A third innovative approach that we are very proud of is the way that our medical specialists have been incorporated into primary care. We accomplished this by a focused retraining program, by hosting a series of seminars designed so that the specialists and generalists could meet on common ground and get to know one another, and by setting clear visions, goals, and expectations. We didn't have enough staff to run this clinic any other way, but the concept of having specialists involved in primary care has worked extremely well and has greatly facilitated cross-consultation and education. Redefining the role of specialists may be one of the most important lessons that we have to offer other medical care systems that face the same challenges as we did. In terms of this program's value, there is no question that we have dramatically improved the quality of medical care at our center. We are doing this in a cost-effective fashion, and we've made real advances in improving the satisfaction of both our staff and the veterans that we serve. Over the past 2 years, the number of patients using our center has grown 15%. the number of patients enrolled in primary care has doubled. Despite this growth, the number of visits to our ER and the number of admissions to the hospital has declined by a third. This reflects our ability to handle problems proactively in the clinic instead of having them first serviced as emergencies needing hospital admission. Every VA in the country, there are 172 of them, have received a mandate to implement primary care. We got the jump on this process by 2 years, and we now have the opportunity to help and guide other facilities that are committed to improving the quality of their patient care services. Thank you.
Thank you. Jack?
Could you tell us which of the other 172 have followed your example, or what your advice or consultation with them has been?
So far, there have been 6 VAs that have implemented primary care programs. We've been contacted by approximately a dozen so far, about half of which have made site visits to our facilities. All of the remaining VA facilities are in the process of designing their system right now and are looking for examples and lessons for how they should do it.
Tom?
Could you tell me, in the process of putting this plan together, whether or not you consulted with the various veterans groups, and if you did, what was their input, and could you give me some idea of what their reaction is these days to what you've done?
Part of our incentive to get this started was the deep dissatisfaction that our veterans had by fragmented care. The veteran service organizations and actually specific patients were involved and consulted in our planning process and are involved in the ongoing evaluation of it. The feedback and the response we've gotten has been extraordinarily terrific, with our patient satisfaction consistently over 95%.
Thank you.
Max?
One of the goals that you stated was to be able to move this ambulatory outreach into the community. In the present climate to federal funding, what are the prospects of that?
Our understanding, there's currently a federal prohibition from us establishing any outreach clinics. We'd very much like to do that. That's the biggest demand that we have at the moment, and we need to do that. Our patients would like to have access points that are close to them, and we're prohibited from doing that right now.
Other questions from the committee? This isn't a question, but I'm curious. Are the buttons you're wearing, I just can't see them that far from here, do they have anything to do with the program?
No, audiovisual devices were not permitted.
But I just happen to be on the yellow team.
David has a question.
I'm curious to what extent your decision to set the program up was based upon practices in other hospitals not in the VA system. In other words, were you borrowing a lot of ideas from other hospitals, ideas that are already in practice?
The final product resembles a multi-specialty group practice very closely. It wasn't designed that way. It didn't start out that way, but that's how it ended up. There are many unique aspects of our system that differentiate it from that process. For instance, we incorporated education as one of our major missions. We are affiliated with a state university. We have 100 residents that pass through our program every year and 200 students. So in addition to delivering a high quality of service to our patients, we need to build a system that delivers a high quality of education and allows these people to see primary care as a viable role model, something they might want to do when they grow up.
What I think is hard for a lot of us to evaluate, at least it is for me personally, is what the program sounds novel within the VA system. Why is it innovative?
The innovation was primarily internal. None of us at the VA before this system viewed the patient as the center of care. It's obvious after it's done that that's the way it should be, but that's certainly not the way it was.
Max?
I think all of us were hesitant to ask too many questions, but one of the ones when you mentioned the replicability into these other 6 to 12 VAs around the country, if this is not a voluntary, if it does not happen as it did with you kind of internally, I had the impression it may not work. If you're told to do it, it's much different. How do you handle that in a highly bureaucratic organization?
Well, 2 years ago, in the climate of healthcare we were reform, we were told that if the VA couldn't compete, the VA would be eliminated. Now,